Good morning, dear ladies and gentlemen. A warm welcome to all of you to today's webinar organized by the Society for Health Research and Innovation Academy. We truly appreciate your presence and commitment to continuing professional development. Before we begin, let me share a few important points regarding the webinar proceedings. The link to join the webinar will be available until 9:50 a.m. and access to the session will close promptly at 9:50 a.m. Late attendees will not be admitted beyond this time. By participating in this program, you can earn 1.5 CPD points, and participants must remain until the end of the session to receive your CPD certificate because the Shri webinar series strictly adheres to NCCPD guidelines. I hope you will keep your microphones and videos turned off throughout the session to ensure a seamless experience to everyone. You can ask questions via the chat option at any time, and your queries will be addressed at the end of the session. If you have a very specific question to clarify, which you think you cannot ask here, you can email us on office313@gmail.com, the address shown in the screen now. After the webinar concludes, stay another few minutes and ensure you fill out the Google form provided in the chat box with post-assessment questions to receive your CPD certificate through email. This form must be submitted before 11 a.m. today. We sincerely appreciate your cooperation in ensuring a smooth session for everyone. Moving on to the topic, cultural competency for doctors, we have a well-versed resource person today with us. Hope you all know by now, she is Dr. Santhushya Fernando, Senior Lecturer, Medical Humanities, Faculty of Medicine in University of Colombo, with years of experience as a consultant community physician. She also has received Teaching Excellence Awards for large groups as well as small groups teaching for humanities, society, and professionalism stream in University of Colombo. This will be an interesting session for everyone who needs to learn the concept of cultural competency, how it is relevant to our doctors, and how should we develop cultural competency while working in a multicultural society like ours. And it will also helpful even the doctors who are looking for professional career in other countries as well. Over to you, madam, to continue with the informative session on cultural competency for doctors.
Good morning, everyone. I'm very happy to be here. Thank you all for joining on a Sunday morning. My topic today is a cultural competency for doctors. The healthcare provision and community care of health has changed over the years from a paternalistic, hierarchical, power-based one to a more person-centered and patient-centered model. So when you try to give patient-centered humane care through our medical and healthcare delivery systems, cultural competence becomes a very important component of it. You may have heard of this term, you may have not heard of this term, but I think you all know the importance of culture in medicine and in healthcare delivery and also in understanding people. So I will go straight to my presentation where I will walk you through these concepts and hope to have a good discussion at the end of this program as well, at the end of my lecture. So my topic today is cultural competence for doctors. This is the outline of my lecture today. We will go through the aspects of culture, understanding culture, health and culture, and we will answer the question, what is cultural competence and what is the importance of cultural competence for future doctors and the limitations of cultural competence or demonstrating cultural competence. So there are lots of definitions, dictionary definitions, anthropological, sociological, cultural, psychological definitions, but this is my favorite definition of culture, defined by Sir Edward Bernard Tyler. He lived several centuries ago. He's a cultural anthropologist who was very much influenced by Charles Darwin, and he had a great connection to science apart from his role in humanities. And he said culture is that complex whole that includes knowledge, belief, art, morals, customs, and any other capabilities and habits acquired by a man as a member of society. He probably meant a woman too. So when we think of culture as an abstract or an instant thought, we think of culture as the way people dress or the way people adorn themselves, the kind of music, dance, traditions, holidays, festivals. This is what we think of culture at a given point if we were asked suddenly. But Tyler here looked at morals, capabilities, habits of human society or a group in a society as culture. So it's very important to understand culture, what culture means in a deeper context. Now we will move on to what is surface culture and deep culture. To explain this, I will share with you the cultural iceberg. Now you know about the tip of the iceberg, the Titanic ship, and in many other when explaining many other concepts of medicine, also we say this is just the tip of the iceberg. So on the tip of the iceberg are the food, the flags, the fashion, the festivals, the performances, literature, language, the things that we easily attribute as culture. You might remember when you were in school as a small child, for Independence Day, which is also coming up in a few days, we would be made to dress up as the different ethnicities, even if there was not a Tamil person or a Muslim person or a Sinhala person. One person will dress up as that person, and we will say, okay, now we are representing the Sri Lankan ethnicities or Sri Lankan culture. So these are like the things, components of culture that is very apparent easily. That is called the surface culture, what we can easily see, observed by the eyes. These are conscious practices. If we have to dress up to represent say the Tamil culture, we might get dressed in an Indian sari, put a pottu, put some flowers. So these are things that are captured. They're very surface, superficial aspects of culture. But then there is a waterline between the surface culture and the deep culture. Now, the deep culture is what happens in the unconscious, subconscious mind or in our perceptions. Now, that is not really observable. For example, in the surface culture, say some phenomenon of culture like caste. In Sri Lankan society, we don't talk very openly about caste. In Indian society, it is a very normal thing, like talking about your religion or ethnicity. They will refer to caste. But in Sri Lankan society, in the surface culture, we would say, no, we don't take it into consideration. It's not a very potent predictor of behavior. So we would say it in the surface. But when people vote in elections, when people get married, when people interpret behaviors, if someone has angered you, when there is conflict between communities, people might talk about caste, but under the surface. It is coming from the deeper aspects of our culture. So the deep culture of a society is in language and body language. So how, like, do you really make eye contact directly? In some cultures, you don't look at a man may not look at a woman's eyes directly. That would be disrespectful. In some cultures, they're very careful in how you touch or the hand gestures. Like if you do this, that would be aibuan or like respect or namaskaram. But in certain cultures, you don't even give your hand to shake hands until the person with the higher power extends it. So the posture you assume, you can see that in Japanese culture or in our own culture as well. Then there are other things like social norms that are not in the surface culture but in the deep culture. So social norms are like, what is polite? Do we open a gift as soon as we get it? In the Western culture, that is a mark of joy and respect if you open it and appreciate the gift then and there. But in Sri Lankan culture, we usually don't open a gift. You keep it and you open it later. So what is considered respectful? In some cultures, you give special preference to ladies, and it is considered gentlemanly or kind or considerate to, offer a seat, open the door to a lady. In some other cultures, a lady might say that I'm an equal member of society. Why are you treating me like a weak person? So the social norms of the deep culture differs from culture to culture. Then there are things like mindsets. What is happiness happiness, what is love, what is work. In cultures like Japan, you're very committed and you give your life to one organization or institution. In other cultures, a good work life would be to have many exposures in different organizations. And then there are the views and values that are in the deep culture, like what do we mean by justice? How do we treat our animals? What do we mean by aging? Do we age as a society, or do we age individually in an elderly care home? Do people feel guilty for sending a parent to a home, or is it a norm, and is it considered like a good thing to do to give specialized care for a parent at a elderly home? So what do we mean by community? What do we mean by good and bad, right and wrong? And then there are the core beliefs that are a part of a deep culture, such as where the religion, spirituality, life purpose, these things play a role. So the deep culture is not always apparent, but the surface culture is very much apparent. So now we come to the examples of deep culture for us to get a better understanding of what I'm trying to say here today. So, for example, if you say take a maternal death, if a maternal death happens, it's a big issue in the healthcare setting in Sri Lanka. Sri Lanka has wonderful maternal mortality rates, and so in the deep culture, in the medical culture, maternal death would be followed by a maternal death investigation, and it becomes a data. But if you take the deep culture as to what a mother means, I would just like to share with you this Sinhala folk poem. It says, the translation is down there. It says, Irapaya iravarata yannepa, Sandapaya sanda mudunata ennepa, Pedi diyata boradiya ekwannepa, amma neti apata badigini mennepa. So I don't know, I'm sure most of the Sinhala people here are very familiar with this song. But if you decode this song, you can understand what motherhood means in the deep culture. So irapaya ira avarata yannepa means, ira avara means when the sun starts to set after 12 noon. So 12 noon is the time when you think of lunch, you become hungry for the day. And sandapaya sanda mudunata ennepa, may the sun not reach mid-evening. So mid-evening on a full moon day, by about 7, the moon would reach its full glory. So around the time dinner time, when you get hungry. So then if your mother is not there, you don't have lunch, you don't have dinner in the rural Sri Lankan culture. So then all that is left is like the water in the lake or a pond. So they say, so you have to drink water to satisfy your hunger. So therefore they say, may the clear water not go murky. Paddy there is the clear water. Boradia is the muddy water. So if the water becomes muddy, you can't even drink that. In the absence of your mother, you have no food. And then they say, Amma නැති අපට බඩගිනි වෙන්න එපා. So may the motherless kid never feel hungry. So this poem deeply captures, apart from a health data, what does a mother's death or mother's absence means. So I remember Dr. Anoma Jayatilaka. She was a legend in maternal and child care. Whenever a maternal death happened, she used to show a picture like this that you see on the screen. And she says, don't talk about maternal death as a data, as a number. Just erase this mother from this poor people's home. They are already having so many problems, as you can see. If you erase this mother, what would happen? And don't talk about the maternal death as just a death. You please tell me what were her dreams, what were her aspirations, what is her story. So if you go when she used to teach us maternal and child health like this, we used to understand, even though we were unmarried young girls, we used to understand what mother meant to the deep culture of Sri Lanka. So if you take this cultural iceberg, you can see under what headings the concept of mother means in the deep culture. So you can see that it covers a lot of domains of the deep culture, although it is one word. So we will take another example. It's the hierarchy. What is the doctor? Now you see in our doctor relationships, in our culture there is a practice. You call your elder colleagues like Ayya, Akka, and there's a lot of discussion whether we should call our seniors sir, madam. A lot of people who come after their foreign training, they write long posts on social media about in Western countries. My boss doesn't call me, doesn't want me to call me by as sir or madam. It's a very egalitarian or equal society, and why are we calling our bosses sir, madam? It's a lot of cultural conversation about these issues in our doctor-doctor relationship discourse. But the doctor-doctor relationship, how the power balances work, and what are the benefits of this kind of a close relationship where you give the name of a family member like Aya, Akka to one of your colleagues. It's a part of our deep culture. This is how our network is set. There are good and bad in these power relationships, but at the same time, many of these doctors who say that we should not respect our elders or use respectful words to refer to our elders when they set up their wards, they might not really want the sanitary worker or the attendant to call them by their name either, because the way Sri Lankan society works is different. Because in Sri Lankan society, the lower categories of staff are recruited not through a very systematized system. They come through political influence or lists, so they may have different characteristics and different power dynamics. And if you don't have this hierarchy, sometimes in Sri Lankan rural settings or in Sri Lankan even city settings, in even general hospitals, it might be difficult to operationalize it without some form of hierarchy. At the same time, we all believe in respect for each other, egalitarianism, no abuse of power, and to lessen the power gap between a doctor-doctor relationship. So also there is a doctor-patient relationship. In another country, a patient will never call you puta or dua. They will never really call you like that. They will probably call you doctor. But in Sri Lankan society, sometimes our patients are very affectionate towards us. It may be very true, very genuine, or maybe it is even a put on for their own benefit. But many times people call you dua, puta, and in some rural settings that I have worked, they even call the doctor Magadeya. So they talk to you like this, and we don't get offended, because in our deep culture we understand that this has a cultural context to it. Whether it is right or wrong, or how much we want to professionalize and sanitize this relationship, is another matter. It's a cultural conversation we should come up with. And there are ways that we in this in the deep culture, there are ways that we compensate these doctor patient relationships and doctor relationships. In our culture, you will offer to cover some work, you will offer to clerk some patients. You work in a collectivist manner. We face tsunami, COVID-19 as a team, as a force. So these are all also part of our society. The reason I put this little deer over here is to share a personal anecdote. When I was an intern in base hospital Dambulla, I treated a patient who was very drunk, with who came with a cut in the hand, and I think I was very gentle and kind to him. And although he was drunk, before he left, he said, you were so kind to me, I'm going to bring you a gift. I said, no, you please don't bring me gift. But a few days later, he brought a little deer in a small tractor, and he said, I'm so touched by your kindness. I brought you my favorite deer. Please take it as a gift. So I said, no, I cannot accept a deer. But so in our culture, people feel, in our deep culture, this gratitude, the doctor-patient bond, emotional reciprocation is sometimes, you get these extreme examples like, a patient brings you a deer. And he even said to me, please accept it. It's a very respectable deer. It's a very good deer. So, things like this happen in our culture because the power relationships are different in our deep culture. So this is just a mapping of hierarchy in the deep culture. So you can see once again, how do we give, stand? What is the distance between two people with different power? What do we mean by respectful or polite? And how does hierarchy come in is influenced by our religion? Because most of our Asian religions give a lot of respect for our teachers, elders, people who are wiser, elder, so like this. So these come under the domains hierarchy. The concept of hierarchy comes under the concept of deep culture. So let's go and visit another example to understand deep culture. For example, what is our surface claim about integrity? We all say we are very honest, we are doctors, we don't cheat, we don't we are a very noble profession, and so on. That is the surface culture. Being a doctor is in fact in Sri Lanka synonymous with prestige, with integrity, with excellence, things like this, and we also think of ourselves like that. But as students or as PG students, do you forge signatures? Yeah, it is a very much a part of our deep culture. Medical students, as well as in other forums, people forge signatures. So that our deep culture is to maybe do it. Do you do fraudulent extra duty claims while you're at home? Do you write your diary as if you were there? So in the surface culture, we are very respectable and very pristine, but in our deep culture, this is actually a norm. False rosters while you display many doctors on a roster, but you're taking unofficial leave and at home. So what is our integrity? What about the COVID times? Did you jump the queue to get the vaccine for your family? Family members? Did you do things that were in violation with the guidelines? Maybe at that time you had a self justification for it, but even today, when you reflect on it, do you think if you had done it, you did the right thing? So, so deep culture is what we don't talk about when it comes to integrity. Surface culture is what we proclaim to be. So so once again, this also comes under these domains of views and values, our core beliefs. Right? We may call ourselves honest, but are we really honest in our deep culture, the unspoken culture? So then we go to the another final example. So, okay, here is a picture from the Pride March of the LGBTQI community. Diversity, inclusion, and equity is a big theme in healthcare in the modern world today. But what do we define as gender, right? Do we have very firm views about gender? Now, President Trump in the USA says from now onwards, for the purpose of government and military in the USA, there are only two genders. But what do you think about it? How do we respond to a person in the gender spectrum? Do we make fun of them? Do we, in the surface of it, you pretend to respect them, but in our private conversations, do we use dirty words, abusive words to describe them? Even as a doctor, if you are in a fight or a conflict, when you want to insult another person, do you invoke LGBTQI related abusive words to abuse another person? So, do we impose our personal beliefs on our patients who come with an issue, a health issue belonging to this community? It is just an example. So, on the surface of it, we might be very compassionate, very tolerant, inclusive, but in the deep culture, how do we actually behave towards them? How do we actually make decisions about them? How do we actually attune our health system to respond to them? So the diversity and inclusivity in the deep culture, I mean, do we even look at them? Do we make faces at them? Do we take a very dominant or an aggressive posture with them? Do we respect the expression of their emotions? Are we considerate to their plight? Are we polite to them? Are we respectful for them? But where are these values, the deep cultural beliefs about gender and diversity coming? It may be because of our own sense of what is good and what is bad, good and evil, what is right and wrong. It can be because we subscribe to beliefs about family, about religion, about spirituality. We may be having some influences from our deep culture that is shaping our response to our a person from the LGBTQI community. So it is coming from the deep culture. If you ask in an exam from any of the doctors, how do we address this an issue, a health issue of the LGBTQI community, they will write 100% mark, excellent response. They will get good marks. But when you actually are in the medical practice, what do you do when these issues challenge you? So, in this culture iceberg, um, you see a word called code switching. Somewhere here, I think you can see there's a word called code switching. Code switching is the practice of alternating between two or more languages or varieties of language in conversation. So this means that it is a big part of our deep culture. Now, this academic called Anna Rudolph, at that time she was an academic in University of Cambridge. She has written a book called Special Treatment, where she has examined the professional identity formation, the ideas of privilege and exclusivity in the most prestigious medical college in India called AIMS, All India Institute of Medical Sciences. It is extremely difficult to get into AIMS. They are highly privileged and highly exclusive group of medical students. There she says that the medical students of AIMS are trained in a large public hospital called the AIMS Hospital. And they are the very poor, uneducated, disadvantaged people who can't afford private care come. So from their entire medical training, they are used to talking to the patient as if they know very little or very uneducated, disadvantaged, powerless person. So they carry this flavor of language even as they go up in their profession. So they assume a very arrogant, presumptive, very patronizing sort of a flavor to their language. So the practice of alternating between two and more languages means, so if you know Tamil language, you're speaking to a patient who doesn't know English or Sinhala, you switch to the Tamil language. Or even if you don't know the full Tamil language, you will at least use some words that you have used in your clinical training to make them understand. Or if you talk to in a regional dialect to a person, you will try to talk in a language that they will understand. For example, I remember when I was an intern in Base Hospital Dambulla, in that area, geographical area, the skin changes you get when you that papular kind of a change you get for an allergy. We call it paludanama. In Sinhala, palu means like a bumpy sort of a skin manifestation of an allergy. But in Dambulla, palu is a fruit. They call it karappang. So initially I used to ask paludanama, the paludanama. So they think you are referring to a fruit. Some of them, of course, know it, but very rural, very old people, if you ask what karappang danamada, monahari, if when you eat something, do you get karappang? Then they understand it. So code switching is culturally scaling your language so in a way that people will understand. So that kind of a knowledge and skill comes from your deep culture, that you think that there is a problem in not speaking to a person in a language they don't understand. It is not only the literally the language, the name of the language, it can be the dialect, it can be the attitude you take, and it can be even your non-verbal language in which you speak. So when you speak to a child, you immediately adjust your language to a language they understand, and you even bring your face down to that child's level, and you speak in a slightly more emphasizing way or in a very clear, slow way in the language that child understands. That is called code switching. So now we come to health and culture. So culture traverses all aspects. You already know this because of your training in community medicine and clinical medicine. Clinical practice. You know this. So a person's health choices, health seeking, whether they have the power to come to hospital, whether they have the money to come to hospital, whether you get family support to seek medical treatment. How people have sex, their reproductive health, the mental health determinants, whether they adhere to treatment or not. All these things have a huge bearing on culture. Culture has a huge bearing on these health-related behavior as well. So health and culture are very closely connected, especially when it comes to aging and death. Culture has a big role to play. Some people are very philosophical about death. They want a death that is not with much intervention or ICU care or medical heroics. Some people would like to fight till the end, till the moment of their death. Some people would like to be surrounded by loved ones, family, grandchildren, children, and have that kind of a loving moment at death. Some people might say that no, this will actually be a negative effect. To be surrounded by too many people you are emotionally very attached to, having them around me is not good for my next life. I don't want this trushna or bonding or this samsaric connection to go to the next life. So people have very, very different ideas. Culture has an impact on not only the way people live, but also the way people want to die. Um, so when it comes, so just to share this, to explain this idea. So let's take culture about that LGBTQI example. But the needs and wants of say, for example, a transgender person are not your own, right? And their health issues are very much outside your reality of an average patient that you will see, or your own health reality. Their identity issues, the psychological process they are going through, the emotional process they are going through is very different to whatever any kind of identity issue that another patient of yours would have gone through, or you have gone through, or the way they perceive discrimination, their trigger level for discrimination may be different because of the discourse they have gone through. So, health and culture. So, how do we respond to them? Do we go to our own corner of culture and respond? Or do we try to get the competency to address these issues? Which brings me to cultural competence. The cultural competence is the ability of an individual to understand and respect values. Please take a moment to read this. Attitudes, beliefs, and more than differ across cultures, and to consider and respond appropriately to these differences in planning. So I'm just giving you a little bit of time to read. Okay, so this is cultural competence. It is an ability of an individual to understand and respect. Now, understanding and respect doesn't mean tolerating. Tolerate things like pain, you tolerate something uncomfortable, unpleasant. A really culturally competent doctor knows how to understand and respect them. Respecting is the most important word here. And also, you must respond appropriately. Then it's not enough to understand and respect values. It is also important to, when you are planning, evaluating, implementing a treatment, to consider consider the understanding you have inside you about this other person. So the components of cultural competence are, first of all, active listening. That is very important for you to understand where this health-related behavior or health-related attitude or health-related transgression is happening in the patient or in a community. Then the second thing is to demonstrate empathy. You have to get into their shoes and understand why they think like this from the perspective of their culture, bringing or the deep culture or the surface culture. And then you have to effectively engage and manage. I will uh, 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 explain this further in my coming slides. So, developing cultural competence, developing the understanding, having the skills to respond to it, placing your why you feel a certain way towards a patient in the deep context of the deep culture, that is not something that you achieve and then you can't say, now I'm culturally competent. I have done a lot of reading. I have been very kind to patients. I have, attended this lecture and some other courses on cultural competence. Now I'm competent. No, it is. It is an ongoing process because culture is a dynamic phenomenon and culture keeps changing, norms keep changing, the cultural challenges in medical care also keeps changing. So how do we get there to becoming culturally competent? First of all, you have to be a reader, an explorer of histories, values, customs of other cultures. And then you must have so that is cultural knowledge. So this includes reading about other cultures, being aware of other religions, practices, and so on. The second thing is to have cultural awareness. That is different to knowledge. When you acknowledge and respect why another culture is like that, that is cultural awareness. Now you may have the knowledge by reading, and then you have developed some kind of a respect based on that awareness and understanding. Then you must have the cultural skill. That means to effectively communicate a person of a culture different to yours and to adjust to cultural differences. So how do we do this? Through the medical curriculum at the Colombo University. These are two examples. This is the Humanitas program, the flagship program on medical humanities. So we have done one on called I Am Love. It is on the LGBTQI community. So we invited some artists and intellectuals and academics and some other people from the heterosexual community of Sri Lanka as well. And you ask them, why do you behave this way? People out there in society feel offended when you behave in such a way. Do you understand why this person is offended? And are we right in being offended? Or what is the history behind it? What is the context of these values or beliefs or fights that you do? So when you listen to it from their point of view, you actually develop a lot of empathy. And we use art as a trigger to decode this as well. The other flyer you see here is Does the Kadua Hurt? So that is about linguicism, what it means for a person who has studied in their own natural language like Tamil or Sinhala to adjust into a life of medicine in English. And it is not only about a life of learning medicine in English, it's all about privilege, classism, how other people make you feel small and low and discriminated because of class, privilege, English, and the people who speak a certain brand of English, and what are the Sri Lankan Englishers. So we explore what it means to be the other. So this is so by incorporating these aspects to education and training, you can actually get cultural knowledge, awareness, and a set of cultural skills. And then you have to have the cultural desire. So you have to have an authentic interest. It is not the superficial saying, I know, I understand, yes, yes, I respect. I mean, those are superficial words. The authentic interest and the willing to absorb knowledge from others. And also, finally, you must always grab the opportunity to meet people of other religions, cultures, and communities and backgrounds, different groups, and interact with them, form networks with them, learn from them, be in their environments to understand what it means to be someone other than yourself. So this picture is from the Humanitas program, which we did on our Muslim community in Sri Lanka. Some of you might recognize Professor Rezni Kasim and Dr. Mohammad Rishad. One is a gynecologist. Professor Rezni is a surgeon. And this is when we have a conversation with them, and our students are our audience, where we ask them, they're from the Muslim community. So we ask them, I mean, what does it mean for you to be a Muslim doctor? How is your religion and culture affecting your professional life and the way you think? I still remember Professor Rizni Kazim. He said a beautiful idea. He said one of the most important things I have learned from that is his religion, Islam, is that finally we all become dust. We all become death. We all become nothing. So this has put put money, success, life, death, all of this in context for me. And I am able to be very empathetic because I look at the patient also and think this is a person who's going to become dust. And I'm also a person who's going to become dust. And these values, this philosophical outlook has been given to him by more than even the medical education. I think it has been given to him by his culture. So, when you have these kind of encounters, when you have these kind of beautiful conversations, and we expose our students to these things, they look at it from another person's lens. So that is how we get there. So by developing cultural desire and having cultural encounters. So all these things, this cultural competence, this set of skills will take you to a higher place called cultural humility. Cultural humility is an ongoing process where you self-explore. You ask yourself, why do I feel this way? Why am I responding this way? Is there a more humane and a more inclusive way in which I can respond? Are there better words I can use to explain something to the other? So you do self-critiquing, you revisit your words, you revisit your agenda, you revisit your inner thoughts, you place it in your deep culture and understand, is there something wrong? And when you have cultural humility, beyond cultural competence, you are willing to learn from others. You are willing to understand other person's point of view. And you do this not for the superficial optics of it, but you do so for honoring the beliefs, customs, and values of the other. So now we come to the importance of cultural competence for doctors. So one of the most important things is that this whole society today, the global society, is in a state of cultural diffusion. That means because of the open society of the internet, complicated by the age of AI, the cultural items such as styles, views, values, religions, technologies, it is just a matter of a smartphone in the hand. So the cultural diffusion is very fast. You can see how the McDonald's spread from all over the world, from the USA. It has diffused to everywhere in the world except Sri Lanka, which last year or so it was removed from Sri Lanka, but it is a global phenomenon. So like this McDonald's burger, which is actually an unhealthy food option, but in spite of being an unhealthy food option, the cultural diffusion has happened across the world. So in that way, healthcare workers need to respond to this cultural diffusion. Ideas, the dynamic nature of culture is diffusing everywhere. Norms are changing fast. So we have to be able to adapt to this ever-changing cultural diffusion and respond to it. So I have put like a little bird flying over the green pastures. Some of you must be thinking of migrating to other countries, so-called greener pastures. I appeal to all of you to serve Sri Lanka for some time, at least. However, moving to the component of cultural importance of cultural competence, you have to have the cultural competence to engage with patients in a trusting manner. And it also streamlines healthcare delivery because different people will not do different things in a given situation. If we have the cultural competence and guidelines to adhere to the competent ways in which we work, then we can streamline healthcare delivery. And then, of course, obviously, it optimizes the patient experience and it improves the safety for the patient as well as the healthcare worker. And then especially if you are in social medicine or community medicine, public health, you can have a better engagement with their local communities. In many of the countries, it is a legal requirement, including Sri Lanka, not to harass or discriminate people. Those guidelines are very stringent in Western medical systems, but in all medical systems, this is a legal requirement to have an appropriate response, culturally appropriate response to the patient. So it is not only a requirement for yourself, but also for the health system. And it's also a legal requirement to have cultural competence when dealing with others. So now we come to the limitations to demonstrating cultural competence. So it is not always easy just because you have the cultural knowledge, you have awareness, you have respect, but just because it is so, you can't do everything just because you're culturally competent and you understand why someone is asking. for something, just because a patient or a community says this is my culture, so now you respect it. You can't do things that are in contradiction with the common good of the people. So for example, say a parent asks you to do female genital mutilation of a newborn child, right? They may claim that it is a part of a cultural belief, but it is illegal in Sri Lanka. It is illegal around the world. It is declared as a major human rights violation by the WHO and the United Nations. So just because somebody has a cultural claim on a practice and asks you to do it, you can't do it just because you are culturally aware of something, right? And then you cannot, so you must know that very recently a child in Australia was denied of insulin treatment, a diabetic child, for several weeks because of some religious belief, and the child died, and they have been convicted by an Australian court. So, just because laying a claim on culture, people can't demand illegal acts from you as a doctor. You have the right to say no. And so you have to have that kind of discretion in your mind. You have to be culturally sensitive, culturally competent, but you must always measure it against the core values of our profession and the law of the country that you're practicing medicine in. And then sometimes health systems may not be enabling. This really depends on, and institutional cultures may also not be conducive. So it is in Sri Lanka and in many other parts of the world too, institutions must have a policy of respecting cultural diversity and enabling cultural competence. So if the culture of an institution or a head of an institution is to discriminate people, discriminate certain ethnicities, have a very sort of, some people have very brutal views to going on with day-to-day activities of institutions. So you may have a lot of limitations for demonstrating cultural competence. But nevertheless, you must overcome by education, advocacy, and your being an example by yourself. Usually when you try to behave this way, you get a lot of resistance in some times, but it is this is overcome by education and empowerment of healthcare workers and training such as these, which is why I'm very happy that a lot of people have joined to listen to this. Today, this is a summary of my lecture today. It may be a old concept or a new concept for you. Maybe I have introduced some ideas for you to reflect on. But whenever you do, my take-home message would be, whenever you have a conflicting thought about responding to the other, please remember, visualize that cultural iceberg and try to place where your thoughts are coming from in the deep culture. Because we have a lot of songs, we have a lot of optics, we have a lot of video footage of in our country about the superficial culture. We all like to say we are the Sri Lankan nation, we are very united, we treat each other in a very nice manner. Race and ethnicity, religion, and all these implications on health don't matter. It's all the same to us. But the truth is that it is not the same to us. And I think it is easy to have superficial culture, the surface culture, the optical culture. We can look very united and humane, but if in our deep culture, if we are fractured, if we don't have our integrity, if we don't have our humanity in our deep culture, in practicing medicine, in treating patients or your colleagues or your superiors, teachers, whoever, it is not a good situation. So I invite you to reflect on yourself and think about another way of being, a better way of being, a more humane way of being. And with this, I will finish my presentation. Thank you very much to Dinakshi and Dineshan and GMOA Shri Academy for inviting me yet again. This is my second time I'm here. So thank you very much. Any questions? If I can, I will answer, or I will read and get back to you. Thank you very much. I'm very pleased to be here. Thank you.
Thank you very much, Madam Dr. Santhushya Fernando, for that informative lecture on cultural competency for doctors. And we have received numerous questions via the registration forms and chat box as well, Madam. We'll address as many questions as time allows during the session. A common question received through the registration forms, Madam, that was before the lecture. What does the topic mean? So I hope you all got a clear understanding about what it was. So let's move on to the next question. Uh, uh, they have given a case scenario here as well. It is ethical to a doctor to challenge a person's belief. Let's say spiritual healing in some priests are doing on some healing powers. And can we intervene in their decisions? A baby of 3 years with a bone cancer is taking on a spiritual healer by his parents, leaving the medical treatment. And how should we advise and overcome the obstacles here?
Okay, so this is a very important question. Thank you for that. And this is a ongoing phenomenon in Sri Lanka also right now. I think that is probably why he or she is asking this question. So in a case like this, now myth, spiritual healing, this is it has a very deep cultural root in Sri Lanka. However, if the patient has come to your hospital, you already have some kind of a hold on the patient. So you can actually, rather than, one thing one must not do is to, now for the medical mind, those of us who are trained in Western medicine, now what these parents want to do is a complete no-no for us intellectually. Obviously, it is a no-no for us, right? So what we must probably the culturally competent approach would not be to, you must not scold them, you must not berate them, you must not belittle them, and you must not use this like thuggery type language that it is your child. If you take the child, he will die. Go and be responsible for his death or something, or ask him what sort of parents are you? Are you this kind of like, I mean, this kind of aggravating, very insensitive language you must not use. So actually, you can first of all acknowledge that I know that some people believe in this, but you have already come to this our facility. This is the like you can explain a little bit that others children have got well, in this kind of a childhood. Cancer, probably you can give some statistics, not in a very complicated manner, that they have a high chance of going and getting treatment in the Western medical system. You can even ask them that for now, can you keep the child here? Let's manage here. If you like, you can bring like like a thread that is blessed, or something that is not very harmful, not something that you drink or something. You can say you can get some little talisman or something blessed, and why don't you, if you like, you can keep it here. So you can buy some time by not being very cruel towards them. If you totally sort of abuse them and deconstruct their belief and insult them, you have a lesser chance of holding on to them. So you can actually even get like a more senior person to counsel this patient, and you can buy a little bit of time, and you must be continuously engaging with these parents. So you can do things like that. And I think the doctor always has the right to predict the outcome of what they are about to do based on our medical knowledge. We do have the right, but we must have a culturally competent and a sensitive approach to it, and maybe get more people to exert pressure on this family to take the right path. So the core competence here is to show empathy, not to brutalize them with words, facial expressions, not to belittle them, and to buy some time and give some leverage for their beliefs, but try to retain the child in the hospital system. That's what I would say.
Okay, thank you, madam. There is another question. Is there a deterioration in applying cultural competency in Sri Lanka in recent past? And if so, why? What are the reasons for that?
Well, I can't really declare that there is a deterioration. I can't declare because I have not read any objective data or publications on it. But there are other studies, large scale studies that are done that from the medical student days when they come for to the third year when the clinical training starts, the empathy drops. You would expect the empathy of the medical students to increase when they start their clinical training, but the Sri Lankan studies show that it drops, and it becomes better when they go on foreign training. Because in those enabling environments, they become more empathic and more responsive to these phenomenon. And once they return, it retains at a higher level than the medical student is, but some bad eggs they will drop. So these are the from the medical education side, this is the data we have. I don't think from my sort of generally my observations, I do and historical sort of analysis also, I don't think it is declining. I feel that the new generation is so much better than us and our elders as a whole, because earlier Western medicine had a very paternalistic and a very big difference between the power asymmetry was very much. People used to shiver when they went in front of a doctor, and nowadays it is not like that, because this kind of cultural competence, behavioral sciences, medical humanities, they are playing a big role in communication skills, ethical and moral reasoning. So I think the future looks much better. And also because of the open society of the internet, misbehaviors, transgressions are reported very fast, and people are conscious of that as well. Maybe it's not a very fair thing, but it is also acting as a deterrent. If you think about it, the knowledge on these issues are becoming more widespread, and the cultural competence, humaneness, communication skills, moral reasoning are becoming very, very important parts of the education. So I think it is not like that, but I think the future generations of doctors in Sri Lanka who are well trained will take our medical landscape to the next level. I am very hopeful about that.
Okay, madam. The next question, actually, you discussed about this topic in your lecture as well. But since a lot of people have asked this question, I'm asking this, madam. What is the legal aspect of not considering as well as considering the cultural aspect in treatment in Sri Lanka? Is there any cases happened earlier? That is the question, madam.
Okay, there are no hard and fast rules that mandate us to adhere to somebody's cultural belief. The law is very nondescript at the moment. For example, there are some sects in Christianity. They don't accept medicine. Some people don't accept blood transfusions. Those sort of sects of society are there. So is there a law against it? Not really. But we can do many things in the interest of the patient. But the question is there a penalization for the doctor for disrespecting the wish of the patient? No, there are no hard and fast rules. One thing we must realize is that culture is a dynamic thing. Even the way a human being thinks in the course of one cycle of disease is also a dynamic thing. This big part of being a doctor is not really, everything that a doctor and a patient faces in this journey together cannot have flaws because it is unpredictable, it is diverse, it is panoramic, it is complex. So I think the biggest, although there is no penalizing as such in Sri Lankan law, for you, somebody can't say that, I asked for this and she disrespected my culture, now I'm suing you. There are no outright cases like that. So I think most part of this is it's a relational thing. It's a relationship thing. It depends on how much you can negotiate with the patient. For that you need a skill set, and you have to have a very high level of emotional intelligence to engage with a person in a situation like that. So it is not really protected or directed by law. It is actually, it's not a nitya, it's a rithya or a tradition. It is a guide. These are a set of guidelines, a set of moral guidelines or emotional guidelines or humane guidelines. So I think we are working in a very mercurial sort of a very nondescript sort of a space. So no, simple answer is no. You can't be sued outright, but you cannot discriminate people. You can't call people names. We saw that a lot in the COVID times when certain sects of society were discriminated even by the medical community. Some ethnic groups, sometimes people who were returning, some expatriates who were repatriating to Sri Lanka to save their lives from COVID. Then some people who were garment factory workers, where some of the clusters broke, epidemics broke. So no, you can't discriminate them, you can't brutalize them, you can't violate their rights, but at the same time, you can't be sued for a specific cultural thing. But we operate in this area of dialogue.
Okay, madam, this will be the last question. Are there any courses to update on it for a doctor who is working in a government sector? And are there any books we can use to develop our cultural competency?
Oh, that is a wonderful question. I will actually send a list of books and papers that you can read about cultural competence. I will soon, you can please share it with everyone. I think this book by Anna Rudock, it is freely available online. So you can download it. It's called Special Treatment by Anna Rudock. It actually resonates a lot with Sri Lankan medical faculties because the selection process to AIMS is very much similar to how we select students for this our medical faculties. And there are lots of other excellent books on cultural competence, cultural sensitivity, social medicine. And I must actually mention here that I learned most of these things by following a course in University of Oxford, social anthropology course. That now after the COVID season, it is now available online as well. So many top universities in the world have online courses for cultural competence, cultural sensitivity, all for medical professionals. So please, you can. For a very nominal fee, you can learn. Some of them are free. So Stanford University, Oxford, Yale, Harvard, they all have these free online courses. We don't have one in Sri Lanka. Hopefully, in this year, the Department of Medical Humanities will offer a small course for credit. So we hope to do that as well. But in the meantime, I will share a list of books, and please you can please get yourself updated by these online courses. They are very interesting, and the world's great philosophers, thinkers actually teach in these courses in these top universities. Personally, for me, I can share a list that I have used for my social anthropology course in Oxford, as well as a list of several books that I have actually borrowed from Professor Panduka Karnanayaka. He's a person who thinks a lot in these domains, and some of his speeches are, I think, also available in maybe open access, YouTube and so on. There are other scholars like him who and many others in medical humanities who have given many lectures like this. You can please follow them as well on YouTube.
Okay, we have come to the end of a wonderful session, and thank you very much, Madam Dr. Santhushya Fernando, for your informative lecture on cultural competency for doctors. We had more than 400 doctors in today's session, and your expertise has definitely provided all of us with a good understanding of this often overlooked area. And your dedication to sharing your knowledge with us is greatly appreciated. And to all our participants, thank you for joining today's free program. As mentioned earlier, the link for feedback and post-assessment questions is now available in the chat box. Kindly take a few minutes to provide your feedback and complete the post-assessment to receive your e-certificate within coming week. The SRE program will continue next Sunday as well with another relevant clinical topic. We warmly invite you to join us once again for another productive session. Thank you, Madam, for your time and for sharing your expertise. And thank you to all the doctors who participated today. We look forward to seeing you again next Sunday morning. Thank you and have a nice day.
Thank you. Thank you very much, everyone. Thank you.